Good morning, and we thought we'd start off with something very exciting, neurological disease this morning, in terms of an easy topic. No, seriously, we're going to talk for this first session about various neurological conditions and their association with sleep, okay? Um, and kind of touch on many of those, and you'll see how much this affects all these different conditions. And in fact, that's kind of what drew me to the field of sleep medicine. Was during neurology training, there were so many different conditions where a particular faculty member who was really cued in to the effects of sleep would always ask the patients, well, how are you sleeping? And then he'd uncover all these underlying sleep disorders. And then it's amazing how much you can impact all of those by addressing someone's sleep. I have nothing to disclose in terms of any kind of conflicts of interests. So some of the different categories of neurological disease we're going to touch on are cerebrovascular disease or stroke, REM sleep behavior disorder, the synucleinopathies and Parkinson's disease, and we'll talk a little bit more about what those exactly are. Multiple sclerosis and demyelinating illness, Alzheimer's disease, headache, neuromuscular conditions, and briefly COVID-19. So we'll start with cerebrovascular disease, and so everyone thinks about the typical risk factors for this, including things like high blood pressure, the poor cholesterol control, blood sugar with diabetes, obesity. You see more of it in males and in minorities, even though over the years some of that gap is narrowing a bit because of other risk factors. Ischemic heart disease, atrial fibrillation, where the chambers of the heart quiver and it's easier for a clot to form in there and then embolize. Carotid disease, where you have any sort of prothrombotic effects from a carotid plaque rupturing potentially, and then other clotting disorders. But chief amongst those in terms of our attention this morning is sleep apnea as an independent risk factor. And it's not just sleep apnea, but snoring also. Both are independent risk factors for stroke, okay? So that's why it is important, and snoring, even though for decades many of us just kind of chuckled at snoring, it is quite significant. So anytime you see that, you want to address that. And other associations between stroke and sleep. Stroke is the least common in those late evening hours up until midnight. So you don't see you definitely still see it during of most people's sleep, right? So a lot of times you've probably heard the expression wake up stroke, and in those instances it's difficult to be able to give some of the different clot busters based off time frame, even though those windows are expanding, so it's making it a bit easier. But if you don't know when the onset was, it certainly complicates that process. Further compounding that is the fact that our blood pressure is lower at night by anywhere from 10 to 20%. And you get decreased fibrinolysis or breakup of clot in the early morning hours based on just those humoral factors or blood factors that we have and their activity levels. And you get increased platelet aggregation where they stick together and can occlude vessels. So, all this comes together with this incidence of sleep apnea, and what commonly comes during that second half of the night, more stage REM sleep. And what's worse during stage REM sleep for many, many individuals? Sleep apnea. So, not hard to see how all those things can align as a perfect storm to dramatically increase risk for stroke. And it's because during stage REM sleep, obviously you don't have the same activity with the accessory muscles. You have the diaphragm working, but you don't have that additional benefit from the accessory muscles working to help prevent worse sleep apnea. Sleep apnea is very common in stroke individuals. It's independent of blood vessel diameter, so it can be large vessel hemispheric strokes to small vessel, what we call lacunar strokes. Even though they're small vessel, they can be still quite devastating just because a lot of the neurological territory where the smaller vessels are, it can be very precious territory because it's where those pathways narrow down into the brainstem, for example, and still cause a hemiparesis or weakness on one side, for example, things like that. At really all different AHI levels, you can see that in much higher percentage of stroke patients versus controls, and that's in various studies, and oftentimes in a ratio of 3 to 1, so much more prevalent versus the control population. And it's not just because of the inherent effects from sleep apnea. Don't forget, sleep apnea compounds many other things. So sleep apnea makes high blood pressure worse, worsens blood sugar control, and so forth. So in that factor, it also contributes and compounds the issue. Stroke sufferers who have sleep apnea do have a higher mortality after stroke. So all the more important to identify that and treat that. And obviously much more advantageous to identify it beforehand, before any of this, even if the individual still has a stroke. Obviously, the longer they're treated and the number of years, the better in terms of health outcomes and effects on that vasculature health. Because the repetitive norepinephrine releases that you get with each of those apneic episodes leads to a lot of vessel constriction and damage, leading to thicker vessel walls. Those thicker vessel walls are more susceptible to rupture, and then that plaque can really be a nidus for clot formation and potentially even embolization down the vascular tree, which is basically higher up into the brain. So you can really see effects, like I said, anywhere in terms of stroke distribution. So apnea and the actual mechanisms contributing to stroke include a lot of those different hemodynamic changes, like I mentioned earlier, including all the alterations with fibrinolysis, with this further decreasing that effect, decreasing cerebral perfusion pressure. And in fact, during an apneic event, you get about a 15 to 20% reduction in cerebral blood flow. So when you think about it, that's quite substantial. And we're not talking cumulative over the night. We're talking with each apnea at that time, the blood flow decreases by 15 to 20%. Certainly not hard to imagine the effects that could potentially have. And we've already talked about how the intermittent hypoxia can be associated with the inflammation that leads to those blood vessel effects that definitely make them more susceptible to plaque rupture. It is related to severity in terms of increased stroke risk. So the more severe the sleep apnea, the more it increases your risk for stroke. So it's not just one of those issues of do you have it. So much like other things like blood pressure, if you have severely elevated blood pressure, obviously that's much more of a risk than just very mild. And the same is true with sleep apnea. The more severe, the more risk that does indeed pose. And treatment does have a substantial impact. So treatment with CPAP not only lowers the mean blood pressure, but it yields an approximate 20% risk reduction for a stroke. So that's quite significant, okay? And it's not just obstructive sleep apnea. Central sleep apnea also poses risk and has an association with stroke. Everybody in this room, of course, knows this is an issue with the signaling for breath initiation during sleep. But in the past, studies have found that it is present, CSA, in anywhere from 10 to 30% of acute stroke patients. So it's felt that it does increase in incidence after stroke oftentimes. Some more recent studies have kind of called these numbers into question and feel that it's a bit lower. They weren't perfect studies though, so we kind of need to see exactly what that prevalence is. So it may be slightly lower, but still, regardless, it's definitely in a higher number than you see pre-stroke. And it's because the ischemic lesions resulting from the stroke can affect the brain centers controlling respiration. And it can be hemispheric, it can be infratentorial or in the brain stem. Those are both areas where you get increased risk for CSA development. But right after someone has a stroke is not the ideal time to do your sleep testing to really determine what's going on, because oftentimes as you get improvement from the stroke effects, you can notice a lessening of their degree of central sleep apnea in particular. So ideally, now certainly if you identify sleep apnea, you want to try and treat that as soon as you possibly can. But ideally, in terms of determining what degree of sleep apnea and what type of event someone is having, it's ideal if you can wait at least 3 months or so after they've had their stroke to actually do your testing and see. And I do recommend in-lab testing if at all possible, just because it really helps to delineate those types of events. And of course, just don't forget that stroke is not the only thing, of course, that increases the risk for central sleep apnea. It's things like heart failure, things with prolonged circulation times, atrial fibrillation, and people being on opioids. Some strokes themselves can lead to excessive daytime sleepiness, and stroke can, in fact, aggravate sleep apnea or cause it de novo, so it's not just pre-existing sleep apnea that's present. Stroke can alter circadian rhythms by affecting inputs to the hypothalamus, and stroke can lead to REM sleep behavior disorder, and that's where you get those common dream enactments at night to varying degrees of severity. And like any lesional pathology, that can lead to that REM sleep behavior disorder release phenomenon. So mentioning RBD, let's turn to that now for attention for a few minutes. Of course, as everyone knows, that's the excessive nocturnal motor behaviors associated with dream mentation and a loss of the normal atonia we get of the skeletal musculature, and resulting in dream enactment, people reaching for things or punching, sometimes punching, kicking furniture next to the bed or part of the bed or their bed partner. And it's been associated with many, many different neurological diseases, not just stroke. The synucleinopathies, it's a category of neurological disease, and that includes Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy. And the underlying process there is that when you have that alpha-synuclein protein deposition, it can substantially increase the risk for these conditions. And we'll talk a little bit more about that in a moment. Narcolepsy, it's very common to see RBD in that. Medications, in particular, the antidepressants are notorious for increasing the risk for RBD.
With the antidepressants and the RBD, if somebody has the legs or whatever, with the legs, with Retinol help that, or is it just not going to matter for the SSRI?
That's a good question because yes, the question was with with antidepressants and RBD, is ropinirole of potential benefit? And ropinirole and the other dopaminergics like pramipexole, for example, and rotigotine, they have been reported to be a benefit for REM sleep behavior disorder, but that's not really been my experience. Those are really more kind of limited case series or case reports where you've seen that there's reported benefit. So there may be individuals, there may be some sort of subset that we haven't clearly delineated yet where that may be of help. But in terms of practical experience, you don't tend to see a dramatic response. Sometimes you can try that and see, and sometimes, there's overlap. Maybe they also have restless legs, and that's causing them to do, some of the things that might mimic. Yeah. But other vascular lesions, various lesional pathology, it doesn't have to be just vascular, can lead to REM sleep behavior disorder as part of a release phenomenon from the brainstem. And other heritable conditions, spinocerebellar atrophy, demyelinating illness like multiple sclerosis, limbic encephalitis, which is an autoimmune process, oftentimes secondary to a primary cancer or neoplastic process where those immune complexes can lead to REM sleep behavior disorder. There have been reports of people having COVID-19 and then experiencing RBD. And it can be part of a withdrawal phenomenon as well from things like alcohol, cocaine, and the amphetamines. There's an interesting association between the synucleinopathies, so Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy, and RBD. And that is that oftentimes the synucleinopathy, the RBD is a harbinger of a synucleinopathy to come years down the road. Not always, but it is very common. Carlos Schenck, one of the first individuals to identify REM sleep behavior disorder, did a study, and this was a number of years ago now, where he found that in 4 years, 38% of those patients developed Parkinsonism. He extended that out and followed it over 13 years, and roughly 2/3 of them had developed either Parkinsonism or dementia. And at that point, at that 13-year point, still about 1/3 or a little better remained idiopathic, where there was no association with any of the synucleinopathies. And there have been various other studies since then identifying that and showing things like 45% of people with RBD eventually developed a neurological disorder at 5 years from the time of diagnosis and 11 years from time of symptom onset. So don't forget, there's that lag time. So oftentimes a lot of these symptoms start, and then it's several years before an individual will actually be diagnosed with the condition that they're experiencing. And in terms of prevalence, it's somewhere between 30 to 60% of Parkinson's disease patients have RBD. Dementia with Lewy bodies, it's somewhere between 50 to 80%. And then in multiple system atrophy, it's almost all patients. And it's kind of interesting too, even though with RBD there's a fairly considerable male predominance to that. In multiple system atrophy, it's the same. The females tend to have it just as much as the males. So, but basically, kind of sum that up, that phenoconversion from not having Parkinson's disease to having it, you're looking at about a 6% per year risk of developing that. And then at about 12 years or so, it's almost 3/4. Okay? All right. So in looking at Parkinson's disease itself in particular, sleep disorders are very common. In the literature, most of the estimates are somewhere between 40 to 60%. In clinical practice, it feels like even more. Just because a lot of times I think for a lot of this, it depends on how much you look for it and how much you ask about it. Obviously, there are a lot of issues to address with Parkinson's disease, so sleep may be one of the things that gets relegated to a little bit lower on the list for some, excuse me, for some individuals. But insomnia is very common and often multifactorial with Parkinson's. And that can be from depression, which is quite common in Parkinson's patients, resulting in those early morning awakenings. Also motor symptoms. A lot of times individuals with Parkinson's will wake up and then things like their tremor, that's quiescent during their sleep, but then it all of a sudden becomes emergent once they wake up. So then they're lying in bed and they experience the tremor. And that tremor can interfere with them returning to sleep or staying asleep. Okay. The medications that you use to treat Parkinson's, including the medicines like we were talking about a minute ago, the pramipexole, ropinirole, those in particular, those dopamine agonists are notorious for leading to insomnia. In fact, even probably 10% or more will experience insomnia on those medications. They're kind of interesting because as a class, they can not only lead to insomnia, but they also commonly lead to daytime sleepiness. So, and it's not just as a result of any insomnia they might experience. They might have one or the other, or potentially both. And with Parkinson's disease, there's a lot of pain. It's kind of a more diffuse, generalized, non-specific kind of pain, but that obviously can interfere with sleep and significantly fragment their sleep. And it's not just those things that I mentioned that can lead to that fragmentation, the medications, the nighttime motor symptoms, but it's also, it can be the neurodegeneration itself that can really interfere with getting into sleep and maintaining sleep. Sorry, I'm losing my voice for some reason. But also don't forget primary sleep disorders can lead to that issue. Okay, so just because you have Parkinson's doesn't mean that you don't have sleep apnea or restless legs. In fact, you commonly see that as well. Oh, thank you. Oh, thank you. So, and in fact, sleep apnea we see in about 60% of Parkinson's disease patients. So in a higher percentage even than the general public. And the motor dysfunction that you get with Parkinson's does predispose to upper airway obstruction, okay? So just like it can interfere with the swallow mechanism, that slowness of movement and dearth of movement can also lead to upper airway obstruction, okay? Excessive daytime sleepiness is also a very common issue with Parkinson's disease. And that's not just individuals who don't sleep well at night. They can experience that during the day. Those dopamine agonists are notorious for sometimes causing just sleep attacks, where without warning, without preceding drowsiness, those individuals can drift off. That's why you have to be really careful when they're on those kind of medications, and you have to warn them and say, this is a possibility. So, when you first start taking this or make a significant dose adjustment, it's ideal if they can do that on a weekend or a period where they have a few days off to see how they react to that. Because it can be dose related. Sometimes a lower dose will not cause that, whereas a higher dose will. And as I mentioned earlier, you can see restless legs with Parkinson's disease. There are a lot of shared pathways there, obviously involving dopamine synthesis, and whenever you interfere with that, you can definitely see both as an issue. And then we've already talked about the RBD and Parkinson's disease, but just wanted to mention here that the more severe the individual's motor dysfunction happens to be. So over the years, as that worsens, that tends to correlate with people who have RBD. So in other words, if you have RBD, they tend to have worse Parkinson's disease symptoms. And not just the motoric issues, but the cognitive issues, dysautonomia like orthostasis potentially when they stand up, and hallucinations in particular that happen more at night when we have less visual input. All right. Now let's turn our attention to multiple sclerosis and demyelinating illness. Anyone who's seen or cared for someone with multiple sclerosis knows that it can really affect almost any neural pathway. It is perhaps one of the most notorious for being able to present with almost any neurological symptom, and sleep certainly is not excluded from that. And sleep disorders are as much as 4 times as common in MS as compared to controls. And fatigue is an almost universal complaint in MS. I mention it here because while fatigue is not necessarily a sleep disorder per se, because there's so much overlap and you often hear both, it's important to kind of realize what role that can play. And fatigue can be primarily due to MS, or it can be secondary to a variety of other things, including obviously sleep apnea and medications specifically that you give for MS. It can be obviously a manifestation of depression, which is very common in this condition as well. There are a lot of different treatments you can use in order to address that, including exercise, strategic napping, where you nap for certain periods of time, for a set period of time, and try and decrease that sleep drive. Sleep hygiene is also very, very important because, obviously they're dealing with so many other issues, the pain, things like that. It's really important to do everything that you can to encourage and facilitate better sleep. But there are also medications that can be quite beneficial, including amantadine or some of the neurodegeneration stimulants like modafinil and armodafinil. And they really all can have substantial benefit for MS fatigue. Insomnia, much like some of the others that we've seen, very common in MS, seen in up to 40% of individuals. And again, just like with Parkinson's, it feels like even more when you're actually treating the patient and bringing up all these different issues and addressing those. And certainly as well, this is quite multifactorial. Again, it can be the medications that they use, the immunomodulators, and the side effects from those. MS pain With MS, commonly you can get a neurogenic bladder, and it's where you get decreased emptying, and this can lead to increased urination needs at night or nocturia. Sleep apnea obviously can be a significant confounding factor. Spasticity. Individuals with MS have a lot of spasticity sometimes, and that can be quite painful. So they'll notice that a lot at night and interfere with their sleep. And if you think about it, that's kind of the time of the day where you're trying to do the most extension of your body, and that spasticity tends to keep things in a more contracted state, so it's more difficult to actually stretch out and release that spastic posture. So obviously that can be quite painful. And mood disorders, depression, of course, being quite common, and other things too. Certainly anxiety, all of that can interfere with someone's sleep. Multiple sclerosis lesions can lead to things like REM sleep behavior disorder. I've seen that, where some individual will have no complaints of RBD, then they'll develop a brainstem multiple sclerosis attack, and then all of a sudden they actually have RBD. So that's not a common scenario, but you definitely can see that. So anybody who has a history of this and then all of a sudden develops something de novo, it can be directly related to where that lesional pathology is. RLS is much more common in MS. Those MS plaques are area of demyelination where the immune complexes they've generated attack the myelin or wrapping around the neurons that facilitate transmission of the signal on that nerve. Can interfere with any pathway, and certainly that includes RLS, and you get that release phenomenon. You can also see other causes for that, including things like medications. So they commonly have depression, so they're on antidepressants, and that can alone be the reason for that, but also it can kind of help bring out RLS. Just like if someone doesn't have RLS and they get started on an antidepressant and they develop RLS symptoms, and sometimes you can remove that antidepressant and then it goes away, that can be another harbinger of RLS to come in the future. Just like pregnancy can, you can place a lot of increased demand during pregnancy. It can bring out RLS, and then after delivery it goes away. Then you can see that later. I just say that to say there can be different things that kind of put stressors on the system that bring out RLS that might not have emerged until years later, but then you can see that earlier on because of those other factors playing into that. MS can also be a secondary cause of narcolepsy, so you can actually get hypothalamic lesions that can lead to a narcolepsy picture. It's actually one of the things that you have to be aware of and look for in terms of a history when someone reports narcolepsy symptoms. And a related condition called neuromyelitis optica, or NMO, that is a demyelinating illness that in particular affects the optic nerve and the spinal cord, and kind of has this largely interesting sparing of the brain and brainstem higher centers. So, and it's because of a particular antibody that's generated against aquaporin 4. And narcolepsy is so common in that condition that it's even considered kind of a core clinical feature. So definitely a lot of associations between the various demyelinating illnesses and many other neurological conditions, including sleep. Let's talk about Alzheimer's disease for a moment. Anyone that's ever cared for or been involved with the care of an individual suffering from Alzheimer's knows that sleep can be a major issue. Okay, there's a lot of loss of orientation to day-night cycles. So this can manifest as insomnia. Sundowning is a very common phenomenon, and that's where once the sun goes down, that's where it gets its name, you get kind of those increases in confusional states. They're not as oriented. An individual may even be, fairly normal in terms of behavior and orientation during the day, and then at nighttime they're dramatically different, much more confused, less oriented. They may not even recognize their environment that they're quite familiar with, all those kinds of issues. It can be a very significant challenge to deal with. And we'll talk in a moment about some of the things that you can do for that. And also, sleep findings in Alzheimer's can be excessive daytime sleepiness. So, and that certainly can be multifactorial. Not only are they not resting well at night with highly fragmented sleep, but they can just doze off during the day and sort of spread out their sleep period over the 24-hour time frame because of neurodegeneration in and of itself. So they're losing those generators for what is day and what is night, and when should you be asleep and when should you be awake. An interesting association exists between sleep deprivation and neurocognitive dysfunction. So we're talking about executive functions, kind of your prefrontal decision-making, planning, things like that, attention, working memory. Working memory is kind of like where you say, oh, okay, what's your phone number? It's 1, 2, 3, 4, 5, 6, 7. And then that's where you walk away, and a few minutes later you think, okay, I've got to write that down. What was that? That was 1, 2, 3, 4, 5, 6, 7. That's your working memory. It's not long-term, it's not stored, but it's essentially, think of it as something on the table that you're using right then or within a very short period of time. And that's what working memory is. And so sleep deprivation really leads to a lot of issues with that. And we've all noticed that, right? If you do nighttime work and then, you notice the next day, it's like, wait, they told me that. What was it? That sort of thing, that can interfere with working memory. So sleep deprivation can lead to all those kind of things, and then ultimately lead to dementia risks. So very important to try and avoid chronic sleep deprivation because it's really felt that disturbed sleep and insomnia chronically going on over years may be a prodrome of Alzheimer's. So definitely not to be ignored. And with Alzheimer's, what you get is an accumulation of beta amyloid and tau proteins. So just like the things like Parkinson's disease and DLB, dementia with Lewy bodies, multiple system atrophy, are synucleinopathies. You've also got Alzheimer's disease, which is a tauopathy. So there's a different protein involved in the deposition of which can lead to pathology. And that precedes the development of Alzheimer's disease by years. All these neurodegenerative diseases usually, that's a process that takes place over many, many years. So it just doesn't just happen within the last 6 months or a year. Oftentimes it's years or potentially even decades. And so that deposition of those proteins can have very significant effects, including increased wakefulness, less slow wave sleep, less REM sleep, and you can get degeneration of the suprachiasmatic nucleus, and that can lead to an irregular type circadian rhythm sleep disorder. That's what we're talking about, especially like with institutionalized individuals where, you know, there are no days and nights. It's just random, okay, in terms of when they're awake and when they're asleep. And some of the treatments can include melatonin, cognitive behavioral therapy, if you can get compliance with participating in that, light therapy, and not just light, but also just increasing cues. So the more you can give someone a cue about whether it's day or night, or for that matter, where they are, that can really help with this. So, you know, this is something kind of we discovered years ago because we'd have people in the ICU with big bright lights on overhead 24/7, right? And so, you know, they didn't know what was day, what was night, you know, once they started, you know, to improve and were aware and conscious. And so that was kind of prolonging recovery and certainly not benefiting them to sit there under a big bright spotlight all the time. So that's why in more recent decades you started noticing ICUs trying to do things like install windows so you can get natural light in there. Also, if you go into the ICU after hours now, commonly instead of the big bright overhead lights, it's much more dimmed kind of light. And all that's to try and increase cues. So you can also do that at home. So you can imagine, like, you know, if your mobility is limited, things like that with Alzheimer's, and you're sitting in a room like this, and, you know, you just kind of don't have as much interaction where you're going out and you realize, oh, okay, this is going on in the world. And I mean, by that, I don't mean necessarily world events. I just mean, you know, people are up and driving to work and back, or things like that. So the more you can increase those cues, the more that can help. You definitely see more obstructive sleep apnea in Alzheimer's disease. And this is an old study, but back then, even in community Alzheimer's, so in other words, people who are still in their same homes, that's as much as 40%. And then when you look at the institutionalized, it's as much as 70%. But, you know, you see that more also too, obstructive sleep apnea, you see it more in mild cognitive impairment, which is kind of like the milder form of Alzheimer's disease, but also the other dementing illnesses like dementia with Lewy bodies or Parkinson's disease with dementia. One thing too you definitely want to keep in mind is with Alzheimer's, they're at increased risk for falls. And in particular, if you use any kind of sedative hypnotic, you know, you think about it, you're trying to use that at night, they've got less visual input because of the darkness, things like that. It really does predispose to falls, so you have to be super careful about that. Apolipoprotein E positivity, that's an allele, so it's a genetic issue where if you're positive for that, that not only carries an increased risk for things like Alzheimer's and cognitive decline, but it also is associated with obstructive sleep apnea. So that may be a part of the reason for that tie-in and association. And treatment, and granted, this can be a challenge, potential, if the individual says, you know, or well, they don't necessarily even say anything, they just rip it off because they're not anxious to tolerate something new being introduced. But that definitely can provide significant protective effects and treatment and improvement even of cognition. And not only that, but if you're predisposed to this, if you have those risk factors and things like that, it can really have dramatic protective effects for those individuals to help at least delay or contribute to the prevention of the development of cognitive impairment or Alzheimer's disease. All right, let's shift gears for a moment and think about headache syndromes. Anyway, migraine's common enough. Most of us at least know a migraineur or maybe a migraineur yourself. And you know that insomnia is very, very common in migraine and headache. And headache severity and frequency oftentimes are associated with sleep deprivation, poor sleep quality. Sleep often helps with headache and migraine relief. So individuals will notice that, boy, and I've had a lot of people say this, the only thing that helps is if I lie down and go to sleep and then try and wake up an hour or so later, and then usually my headache is better or resolved potentially. But the effects and association there are not to be underestimated, because cognitive behavioral therapy for insomnia can convert chronic migraine, where people have it, almost all the time, to episodic migraine, where they may have, 1 or 2 a month, then in almost 50% of patients. So, if you can really get the individual to buy into the importance of this and participate in the cognitive behavioral therapy for their insomnia, it can really have dramatic impacts, sometimes even more so than the treatments that you use for migraine. So most definitely not to be underestimated there. Untreated OSA, as we all know, we've all heard this countless times, it can be a trigger for headache or migraines, and CPAP often improves headache syndromes. Everybody I know has heard about, or many experienced, even sleep apnea headache, where you wake up in the morning and you have this bilateral pressing, sort of dull or fullness kind of sensation present upon awakening. Usually that resolves after the first few hours of wakefulness. It's been felt that may be due to some degree of CO2 increases that you're experiencing, and then over the first couple hours you may kind of breathe that off. But without question, obviously the treatment is CPAP. I can't begin to tell you how many people I see where they come in and say, the thing that absolutely has sold them on their CPAP is they come in and they say, I don't wake up with headaches anymore, So it's really dramatic. I want to talk about a few of the lesser common headache syndromes, but some that are in particular tied in with sleep. Cluster headache, if you've ever known individuals with that, it's very severe. You'll often see these individuals just walking around and they're absolutely non-functional during this. If that starts when they're doing something, they'll be walking around outside and, commonly holding their head, just saying, I can't, whatever they're doing or trying to participate in. They absolutely can't do that. It halts activity. So very severe, oftentimes behind the eye. But it can occur during stage REM sleep. So this can awaken them at night. The duration usually is anywhere from 15 to 180 minutes. Hopefully for individuals it's closer to the 15 minutes because it's quite severe. And they do get associated autonomic symptoms, so redness of the eye, tearing, dilated pupil on one side. So it's quite a complex issue when they're experiencing that. And there are a lot of different things that you can use to treat cluster headache. In particular, people using O2. So sometimes these people will have a little canister of O2, and then they'll use that high flow, as much as 15 liters, and use that for several minutes, and that can really help with an acute attack. There's also something called hypnic headache, and this is where the individual wakes up with a very severe headache all of a sudden in the middle of the night, usually 1 to 3 a.m. It's typically short in duration, even though the duration is listed at 15 to 180 minutes. Usually it's on the lower end, but they're very common. It's 15 or more times a month. There are no associated autonomic symptoms, and some of the things that you can use to help with that are things like caffeine. Melatonin benefits some individuals. If it's more severe than that, you can consider other things like medications like lithium or indomethacin. And speaking of indomethacin, there's kind of a group of headaches called indomethacin responsive headaches, and some people just use that as the grouping of all these different headache syndromes, and they're very acutely responsive to indomethacin, so a lot of times that's worth a try. But there's another rare condition called paroxysmal hemicrania. It's a unilateral throbbing or boring type pain, and that also can occur out of sleep. And it can have some of the associated autonomic symptoms, usually fairly brief, but it is one of the indomethacin headaches. So I mentioned that. If someone has headaches that awaken them during the night, a lot of times, if milder measures don't work, indomethacin certainly can be tried. Neuromuscular disease as a category is associated with hypoventilation, a restrictive lung disease pattern, because these individuals get weakness of the respiratory musculature. Some of the classic signs and symptoms in particular include orthopnea, so shortness of breath when they lie flat. They can develop oropharyngeal weakness, which obviously predisposes to sleep apnea. And kind of the prototypical neuromuscular illness, amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease, is associated with a number of different possibilities, including both types of sleep apnea, restless legs, a lot of muscle cramps, depression, and even a dementia associated with ALS. In these individuals, you want to avoid using supplemental O2 to treat their hypoxia due to possible CO2 retention precipitating acute respiratory failure. Treatment is ventilation with non-invasive ventilation, in particular volume-targeted, or tracheostomy. And treatment of the hypoventilation in ALS with NIV may prolong the survival by up to a year. And that is quite significant because oftentimes the survival with this condition is 3 to 5 years. So you really can have a significant impact by using NIV. Myotonic dystrophy is another neuromuscular illness, a genetic condition. Excessive daytime sleepiness is very common, and that does correlate with the degree of motor impairment that they experience. You see both OSA and CSA. In fact, CSA you see in even a quarter of all these patients with myotonic dystrophy type 1. And again, they get those same type patterns, and the treatment is BiPAP. Epilepsy is associated with obstructive sleep apnea frequently, anywhere from 30 to 50% roughly in observational studies. And in particular, the association to be aware of is OSA can alter your sleep architecture, right? So it can increase seizure frequency because OSA tends to increase stage N2, decrease slow wave sleep and REM sleep. Nocturnal seizures tend to arise from non-REM sleep. REM sleep seems to have some protective effects, and sleep deprivation also can precipitate seizures, but also getting really too much sleep can also help precipitate. Another thing to be aware of in this patient population is anticonvulsants can certainly exacerbate sleep apnea. Some of them in particular associated with weight gain and potentially alter upper airway diameter. One last thing to mention, again, this is something that needs much more delineation and study, but up to 3/4 of individuals with COVID-19 will report some kind of sleep disturbance. And the International COVID-19 Sleep Study findings found increased incidence of insomnia, sleep apnea, nightmares, fatigue, REM sleep behavior disorder, daytime sleepiness in individuals with COVID-19. And, right now we're still kind of speculating about some of the causes, but obviously that can be things like stress, mood disorders, circadian effects, and treatment in particular is cognitive behavioral therapy, attention to sleep hygiene, treat anything else primary that you have identified. All right, so just in summary, sleep disorders can can be associated with increased risk for various neurological conditions, vice versa. Sleep apnea is very common in stroke individuals and other neurological diseases. There's a particular association between things like REM sleep behavior disorder and the synucleinopathies, and often can be foretelling of neurological disease to come. And certainly the focus is on identifying this, treating this early to try and help, and just remembering that prevention is always superior to treatment after the fact. So, all right. Thank you very much. Sorry, I know I tried to hit on a lot of topics. Sleep and neurological disease is a broad topic, so.
Any questions for Dr. Tallent? We got one back here.
Yes, ma'am.
I know that several of your clinics are near VA facilities. Have you noticed an uptick in patients with Agent Orange-related Parkinson's? And if so, is there any clinical difference between their symptoms and your traditional Parkinson's patient?
Please repeat the question for the online.
Sure. The question is with VA patients, have we noticed any association between severity of symptoms and Agent Orange exposure, correct, and worsening, basically? So a lot of different chemical exposures increase the risk for neurodegenerative diseases, including Parkinson's disease in particular, and that's one reason there have been a lot of studies recently that have really shown that the incidence of Parkinson's is probably higher than we think. Right now, you know, the classic that people think of is 1 in 100, so 1% of the population will develop Parkinson's disease. It may even be higher than that, but in particular associated with a different symptomatology. I have not noted that. Now, I admit I do not. It's been close to 20 years since I actually worked at a facility which was associated with a VA. So there may have been other kind of anecdotal things that people have reported, but not that people have noticed, but not necessarily reported. So I can't speak to that per se on a personal experience. But there's no question there's a dramatic association between chemical exposure and development of neurodegenerative diseases like Parkinson's disease, but also the others as well.
All right. Thank you very much, Dr.